Now we will discuss about the vascular supply of the spinal cord. First, about the arterial supply of the spinal cord. The spinal cord, it is supplied by three set of arteries. Along the anterior surface of the spinal cord, there is a single anterior spinal artery. Along the posterior surface of the spinal cord, there are two posterior spinal arteries, and third set of arteries, they are the segmental branches from the various arteries like ascending cervicals, deep cervicals, intercostal and lumbar arteries. So three set of arteries along the anterior surface, anterior spinal, along the posterior surface, two posterior spinal arteries, and third are the segmental arteries. First, about the anterior spinal artery. The anterior spinal artery, a branch from the fourth part of the vertebral artery. Now, the two anterior spinal branches from each vertebral artery, they will unite to form a single arterial trunk, which will run in front in the anterior median fissure of the spinal cord. So, anterior spinal artery, it is formed by the two anterior spinal branches from each vertebral artery. Now this anterior spinal artery, it will become very narrow beyond the cervical regions of the spinal cord. In the lower parts of the spinal cord, it will be reinforced at all the levels by the segmental branches. Anterior spinal artery, it will supply the anterior two-thirds of the spinal cord. So this is the first set of artery, an anterior spinal artery running along the anterior median fissure of the spinal cord. Second set of arteries, they are the posterior spinal artery. There are two posterior spinal arteries, each from a branch from the posterior inferior cerebellar artery. The posterior inferior cerebellar artery is a branch of vertebral artery. Sometimes the posterior spinal arteries, they may be direct branches from the vertebral artery itself. The posterior spinal arteries, they run along the posterolateral sulcus of the spinal cord, and each posterior spinal artery along the dorsal nerve root, it divides into a medial and a lateral collateral branch to supply the spinal cord in the posterior surface. The posterior spinal artery, it will supply the posterior one-third of the spinal cord. So this is the second set of artery, the posterior spinal artery, a branch from the posterior inferior cerebellar artery, and it supplies the posterior one-third of the spinal cord. The third set of arteries in the spinal cord, they are the segmental arteries, which are branches from the ascending cervical, deep cervical, posterior intercostal, or they may be branches of the lumbar or lateral sacral arteries. These segmental arteries, they will reinforce both the anterior and the posterior spinal arteries at all the levels. And in the lower segments of the spinal cord, the some segmental arteries, they may be very large. For example, at the T11 segment of the spinal cord, this segmental artery it is very large and is known as the arteria radicularis magna. And this segmental artery, it will supply all the lower segments of the spinal cord in this region. So this is the third set of artery, that is the segmental artery. If we look at the course of the segmental artery, each segmental artery, it will divide into two branches, an anterior radicular and a posterior radicular branch, running along the anterior and the posterior nerve root respectively. The anterior radicular branches of the segmental arteries, they are larger in size as compared to the posterior radicular artery, but they are fewer in number. So posterior radicular arteries, they are smaller in size, but they are more in number as compared to the anterior radicular branches of the segmental artery. So this is the third set of arteries for the spinal cord, that are the segmental branches from the various cervical, intercostal, lumbar, and the sacral arteries. And they are important, especially in the lower segments of the spinal cord, where they may be very large, known as arteria radicularis magna. So this is about the arterial supply of the spinal cord. The anterior two-thirds of the spinal cord, it is supplied by the anterior spinal artery, and posterior one third of the spinal cord, it is supplied by the posterior spinal artery, and at all the levels these anterior and posterior spinal arteries, they are reinforced by these segmental branches. Now these spinal arteries, they also form a plexus around the spinal cord. So here we can see a plexus that is named as the vasa corona, which is formed by the branches of the anterior and the posterior spinal artery, and branches from this vasa corona, it will supply the superficial parts of the spinal cord. So the anterior and posterior spinal artery, it will form a plexus, that is the vasa corona, around whole of the surface of the spinal cord, and branches from this, they will supply the superficial regions of the spinal cord. Now, the various vascular lesions which may affect the spinal cord, they can be either from the thrombosis, embolism, or atherosclerosis. And anterior spinal artery, it is more affected as compared to the posterior spinal artery. So, if a vascular lesion affects the anterior spinal artery, it will result in ischemia of anterior two-thirds of the spinal cord, and the tracts which will be affected, they will be the lateral spinothalamic tracts and the corticospinal tracts. So patient will have both the motor and sensory symptoms. The motor symptoms in the anterior spinal artery syndrome, there will be a flaccid paralysis at the level of the lesion, but an upper motor neuron or spastic paralysis below the level of the lesion. While the sensory symptoms, they will be the bilateral loss of pain and temperature due to involvement of both the both the spinothalamic tracts. But there will be a preservation of the posterior column sensations, as the posterior one third of the spinal cord, it is supplied by the posterior spinal artery. So this is the anterior spinal artery syndrome due to involvement of the anterior spinal artery and resulting in ischemia of the anterior two-thirds of the spinal cord and resulting in bilateral loss of pain and temperature, but preservation of position and vibration sense. Now, if the posterior spinal artery it is involved, it will result in ischemia of posterior one third of the spinal cord, and this will result in involvement of the posterior columns of the spinal cord. So here the posterior column sensations, they will be lost, but the pain and temperature sensations, they will be preserved, and there will be no motor deficit as no motor tracts they are involved in this lesion. So these are the vascular lesions in the spinal cord, the anterior spinal artery syndromes and posterior spinal artery syndromes. And anterior spinal artery syndromes, they are more common as compared to the posterior spinal artery syndromes. Now about the venous drainage of the spinal cord. The veins around the spinal cord, they form 6 longitudinal venous channels. The 2 longitudinal channels, they are lying in the median position, one in this anterior median fissure and another at the posterior median sulcus. The 2 venous channels, they are anterolateral in position along the anterior nerve root, and 2 are posterolateral along the posterior nerve roots. So total 6 venous channels, they will be formed around the spinal cord, and these venous channels, they will drain into internal vertebral venous plexus and also into intervertebral veins. And through these intervertebral veins, they will drain into various segmental veins and also into the vertebral veins, deep cervical veins. So this is about the venous drainage of the spinal cord, which is in the form of 6 longitudinal venous channels around the spinal cord and which communicate with the internal vertebral venous plexus and intervertebral veins. So this is about the arterial and the venous drainage of the spinal cord. Now we will discuss about the applied anatomy related to the spinal cord. Now, investigations which can be done to diagnose a spinal cord lesions, they are the plain X-ray films, computerized tomographic scans, or we can do magnetic resonance imaging scans. But if we suspect an infection, we can do a lumbar puncture and collect cerebrospinal fluid for its examination.
So these are the various investigations which can be done in spinal cord injuries or lesions. Now, since the spinal cord, it is regulating our sensory, motor as well as autonomic activities. So lesions of the spinal cord, they will be characterized by the sensory, motor as well as autonomic changes. Moreover, sign and symptom of a lesion will depend on the level at which the spinal cord is involved and also to the extent to which the various long tracts of the spinal cord they are involved. For example, if a lesion occurs in C3 to C5 segment of the spinal cord, it will lead on to the diaphragmatic paralysis and respiratory arrest because of involvement of phrenic nerve nucleus. And moreover, if the lesion is in cervical area, there can be paralysis of all the four limbs, that is the quadriplegia. But if a lesion occur at the S2 segment of the spinal cord, it will result in paralysis of only small muscles of the foot. And also the autonomic changes, they are associated with the spinal cord lesions. And if a lesion is at the C8T1 segment, this can also result in autonomic changes of Horner syndrome, where there will be a constricted pupil, there will be a ptosis of the eyelid, and also there will be anhidrosis, that is inability to sweat. While the lesions at the L1 segment, they will be characterized by impairment of ejaculation, while the autonomic changes at the level of S3 and S4 segment, they will result in involvement of bladder, and autonomous type of bladder can occur. So the sign and symptoms in the lesions of the spinal cord, they will depend on the level at which the spinal cord it is involved. And if now the lower segments of the spinal cord are involved, there can be just involvement of the cauda equina, or there can be involvement of the conus medullaris part of the spinal cord. Both type of lesions, they can be differentiated from each other by their sign and symptoms. If the conus medullaris of the spinal cord is involved, there will be a bilateral saddle anesthesia, that means complete loss of sensation in the perineal area. But since in the cauda equina lesions, only the nerve roots they are involved, the patient will have a low backache and radicular pain. In the conus medullaris lesions, there is involvement of S2, S3 and 4 segments of the spinal cord, so the patient will have prominent bowel and bladder symptoms. But in cauda equina lesions, these symptoms they will appear very late, and there will be relative sparing of the bowel and bladder symptoms. So these are the various signs and symptoms with which we can differentiate the cauda equina and the conus medullaris lesions of the spinal cord. Now, spinal cord, it can be involved in various traumatic lesions, neoplastic, vascular, inflammatory, and degenerative lesions. And moreover, in the spinal cord, there can be some congenital defects also. The vascular lesions of the spinal cord we have already discussed, along with the blood supply of the spinal cord, that are the anterior spinal cord syndromes and posterior spinal cord syndromes. Now, other various symptoms now we will discuss. First, about the traumatic lesions in the spinal cord. The most important in which there is the Brown secured syndrome, where there is a damage to the one half of the spinal cord. The cause of this syndrome can be either by extramedullary lesions, or it can be due to some trauma or tumor in the spinal cord. Now, since in the white matter of the spinal cord, both the ascending and the descending tracts are traveling, and if one half of the spinal cord is involved, so there will be involvement of both sensory and the motor tracts, and patient will have both the sensory and the motor symptoms. And these symptoms will be, so if we imagine in this diagram that the right half of the spinal cord, it has been destroyed, and now, the sensory symptoms in the patient will be first about the involvement of the lateral spinothalamic tract. So now the right lateral spinothalamic tract, it has been damaged, and as we very well know that the second order neurons of the lateral spinothalamic tract, they cross from left to right side anterior to the central canal. So this right spinothalamic tract, it is carrying the pain and temperature sensations from the left half of the body. So that means there will be loss of pain and temperature from the left side of the body, even if the lesion is in the right half of the spinal cord.
Now, second sensory symptom will be due to the involvement of posterior column. So now here we can see this right posterior column, it is carrying these sensations of touch and conscious proprioception from the right half of the body. It only crosses at the level of the medulla. So if there is destruction of this right posterior column, there will be loss of touch sensation and conscious proprioception from the right side of the body. So the sensory symptoms in the patient, they will be contralateral loss of pain and temperature, but ipsilateral loss of the touch and conscious proprioception. Now the motor symptoms, they will be due to involvement of the corticospinal tracts. Now here we can see this lateral corticospinal tract. Now this right sided lateral corticospinal tract, it is carrying the impulses for the muscles of the right side now, because this corticospinal tract, it has already crossed in the medulla, and now the right corticospinal tract, it is for the right side of the body. So right corticospinal tract involvement will lead on to the paralysis of the muscles on the right half of the body. So there will be an ipsilateral upper motor neuron type of paralysis. So these various sensory and motor symptoms in the Brown Sequard syndrome will be loss of pain and temperature on the contralateral half, but ipsilateral loss of posterior column sensations and ipsilateral loss of ipsilateral upper motor neuron syndrome due to involvement of ipsilateral corticospinal tracts. Various infections which may involve the spinal cord, they are the poliomyelitis, tabes dorsalis. The tabes dorsalis, it is the tertiary stage of syphilis, and spinal cord may be involved in HIV infections. Now, poliomyelitis, it is a disease caused due to the virus of enterovirus group, and in this disease, mostly the spinal cord, it is affected, leading on to the paralysis in the patients, and these paralysis, they are mostly of the lower motor neuron type. And the replication of poliovirus, it occurs in the motor neurons of the anterior horn. So there is destruction of the motor neurons in this disease. Now, second infection which may affect the spinal cord, it is the tabes dorsalis, which is the third stage of the syphilis infection. And in the tabes dorsalis, the tracts which are involved are the posterior column tracts, but they may be involved in dorsal root, involvement of dorsal root or the dorsal root ganglia. And the patient will have the ataxia of the legs due to the loss of proprioceptive sensations. Now, various degenerative diseases which may affect the spinal cord, they are the amyotrophic lateral sclerosis, tabes dorsalis, multiple sclerosis, and syringomyelia. In the amyotrophic lateral sclerosis, there is progressive degeneration of the motor neurons, and there will be a combined lower motor neuron and upper motor neuron lesions in this type of disease. And some famous personalities which have been affected by amyotrophic lateral sclerosis is Stephen Hawking. Now, other degenerative disease in the spinal cord, they can be syringomyelia. In the syringomyelia, small fluid-filled cavities, they are formed around the central canal, leading on to the destruction of gray matter around the central canal. And since the spinothalamic tracts, they cross over to opposite side in this anterior gray commissure, and there will be now loss of the spinothalamic tract of both the sides. So bilateral loss of spinothalamic involvement due to the degeneration of the gray matter around the spinal cord, it leads on to the bilateral loss of pain and temperature in the patients. And since it affects mostly the upper limb, so there is a shawl-like distribution of the lesions in these patients. Moreover, posterior column sensations, they will be preserved in these patients. So this is said to be a dissociative type of sensory loss with loss of pain and temperature with preservation of sense of touch. Other degenerative disease in the spinal cord, they can be subacute combined degeneration, which can occur due to dietary deficiency of vitamin B12. Now, in these lesions, both the sensory and the motor tracts, they can be involved. There will be involvement of the posterior column tracts and also there can be in motor involvement of the corticospinal tracts. So sign and symptoms in the patient, they will be loss of discriminative touch sensations and conscious proprioception, but there will be also ipsilateral upper motor neuron type of paralysis. So this is the subacute combined degeneration occurring due to vitamin B12 deficiency, and both sensory and motor symptoms will be present in the patient. The other degenerative disease can be multiple sclerosis, where there occur the demyelination of various nerves, and the patient will have the weakness or paralysis of the limbs or the trunk. Lastly, the spinal cord, it may be invaded by the various tumors, and most of the tumors in the spinal cord, they are extradural, that is they are lying outside the dura mater. And these extradural tumors, they are mostly the secondary tumors. The primary source of the tumor can be in the lung, breast, prostate and kidney, and secondarily they have involved the spinal cord. And MRI is the best to locate the site and extent of the tumors. So this is about the applied anatomy of the spinal cord. So now we have completed the topic of the spinal cord with its various external and internal features, and also about the various tracts, ascending and the descending tracts.